Cardiac output is the volume of blood pumped out by the heart in a minute. It is the product of stroke volume and heart rate. With a nominal stroke volume of 70 ml and a nominal heart rate of 72 per minute, it comes to around 5 liters per minute. Cardiac output can vary widely depending on the need of the body. For a 40-year-old person, heart rate can rise up to 180 per minute with exercise. Stroke volume also rises with exercise, but in untrained persons, the rise plateaus off at about 40% of the maximum oxygen consumption. Non-invasive monitoring of cardiac output has been dealt with earlier. Hence, this discussion will be mostly on conventional methods of measurement of cardiac output. The time-old method is the direct Fick principle utilizing the measured oxygen consumption. It was described way back in 1870. It assumes that lungs do not consume oxygen and hence dividing the oxygen consumption by arteriovenous oxygen content difference will give the cardiac output. Mixed venous sample is obtained by pulmonary artery catheterization. Oxygen consumption was measured by breathing into a Douglas bag earlier. Now there are spirometer circuits with sensors which can measure it. Partial carbon dioxide rebreathing is another related method used in commercially available cardiac output monitors. It uses intermittent carbon dioxide rebreathing. A disposable rebreathing loop with carbon dioxide infrared light absorption sensor does the measurement. In this method, the cardiac output is calculated from the dilution of carbon dioxide in blood instead of oxygen in case of direct Fick's principle. Indicator dilution technique was another conventional method using indocyanine green as the dye. A refined technique is pulse dye densitometry using indocyanine green. After a bolus injection, indocyanine green distributes exclusively in the intravascular space. Hepatic elimination occurs with a half-life of 4.1 minutes. The machine auto-calibrates for repeated measurements. Blood concentration is measured with a pulse dye densitogram analyzer which is connected to a clip device attached to the patient's forefinger. Other modalities using the principle of indicator dilution technique which are used commercially are pulmonary artery catheter thermodilution methods and transpulmonary lithium bolus dilution method. Pulmonary artery thermodilution methods are thermodilution with bolus injection of cold saline, continuous thermodilution method, and transpulmonary thermodilution methods. All indicator dilution techniques assume complete mixing of indicator in blood with no loss of indicator between the place of injection and place of detection. Here are a couple of journal references. Cardiac power output is measured in watts, and cardiac power output less than 0.6 watt is a poor prognostic indicator. Cardiac power output is equal to mean arterial pressure into cardiac output divided by 451, which is a constant. Mean arterial pressure is equal to 1/3 of pulse pressure plus diastolic pressure. Cardiac power output has been shown to be the strongest hemodynamic correlate of mortality in cardiogenic shock from shock trial registry. Mendoza and colleagues studied cardiac power output in a broad spectrum of patients with acute cardiac ailment undergoing pulmonary artery catheterization. They had data on 349 patients. Patients with cardiac power output of 0.53 watts or less had a significantly higher in-hospital mortality. Terani and associates evaluated standardized team-based care for cardiogenic shock in 204 consecutive patients. They documented that cardiac power output less than 0.6 watt was one of the independent predictors of 30-day mortality. Prognostic value of peak cardiac power output during symptom-limited cardiopulmonary exercise testing in chronic heart failure was studied by Shen and colleagues. They found that peak cardiac power output was not a predictor of cardiac mortality in their patients with chronic heart failure. The study involved 129 patients. Another study evaluated 36 patients undergoing elective coronary artery bypass grafting. They found that cardiac power output was the only systemic hemodynamic variable which remained unaltered in patients with normal ejection fraction. At the same time, stroke work fell significantly in the period of post-cardiac surgery stunning. Here are the first set of references on cardiac power output. Second set of references on cardiac power output. Conventionally, measurement of cardiac output was done invasively, initially with dye dilution techniques and later on by thermodilution techniques. Both needed pulmonary artery catheterization, which in turn was likely to cause morbidity if used for continuous monitoring. Almost all non-invasive cardiac imaging modalities like echocardiography, computed tomography, magnetic resonance imaging, and nuclear imaging can measure cardiac output. But these are not suitable for bedside monitoring, though echocardiography may be used for intermittent bedside assessment. Assessment of cardiac output, though desirable, was most often time consuming and hence it was replaced by blood pressure monitoring in the intensive care setting. An adequate blood pressure need not mean good tissue perfusion, hence the role of non-invasive cardiac output monitoring. Several technologies with varying accuracy exist for non-invasive or minimally invasive monitoring of cardiac output in the intensive care unit, emergency department, and operation theatre. Some of the methods are pulse wave transit time, non-invasive pulse contour analysis, thoracic electrical bioimpedance, esophageal Doppler, and partial carbon dioxide rebreathing. Though non-invasive monitoring is more convenient, studies have not shown equivalence with invasive monitoring. A meta-analysis by Payton and Associates showed that the percentage error ranged from 41.3% to 44.5%. This was much higher than the acceptable limit of 30%. Bioimpedance method uses a low amplitude, high frequency current passed across the chest and picks up the voltage developed to calculate the impedance. Thoracic impedance decreases when there is more blood in the aorta as blood contains water and iron. Partial carbon dioxide rebreathing technique uses a mask with facial seal. An extra loop of ventilatory circuit creates partial carbon dioxide rebreathing. Cardiac output is calculated using end-tidal carbon dioxide values using Fick's principle. Pulse wave transit time is estimated from the time interval between R wave on the ECG and the peripheral pulse. Pulse wave transit time is inversely correlated to the stroke volume. Special algorithms are used to calculate cardiac output from pulse wave transit time. Esophageal Doppler uses velocity time integral of aortic flow and aortic wall cross-section area as in continuity equation to calculate the cardiac output. This measurement is usually not continuous but intermittent. Aortic valve area can be either predetermined or calculated using age and body weight. Each of the techniques used has its own limitations in the intensive care setting with highly variable cardiac output. Most devices have been standardized using measurements in those with near normal cardiac output. The lack of accuracy in comparison with thermodilution technique is a major problem. Even thermodilution technique has its own limitations in the intensive care setting, so that there is no true gold standard for comparison of the other techniques.